And thank you for joining us for our technical assistance session, substance use, overdose, and brain injury. So integrating trauma-informed, person-centered care. We'll go ahead and introduce ourselves before I introduce Cheryl, our presenter, and hand it over to her. So my name is Ashley Morgan. I'm the director of the Substance Use Deflection Initiative here in the Criminal Justice Coordinating Center of Excellence at Northeast Ohio Medical University, and I'll hand it over to Amari.
Good morning, everyone. My name is Amari McGowan, and I am the program coordinator for the Substance Use Deflection Initiative here at NeoMed.
And then I see Ruth is on. I don't know if you're able to join us and introduce yourself.
Hi, absolutely. Good afternoon, Ruth Samara. I'm the Executive Director of the Coordinating Centers of Excellence at NeoMed.
Thank you, Ruth. And now I would like to introduce our presenter. So Cheryl Stahl, we're thrilled to welcome her as today's featured speaker. She's the Substance Use and Mental Health Program Director at the Ohio Domestic Violence Network, where she supports domestic violence programs in adopting trauma-informed approaches to better serve survivors with substance use and mental health challenges. With more than 18 years of experience in the field, in both outpatient and residential settings, Cheryl brings deep clinical expertise and strong commitment to compassionate, stigma-free care. She's served in roles ranging from crisis line volunteer to program manager, which has included founding and leading a 23-bed women's residential recovery program. She also spent a decade teaching in the criminal justice department at Kent State University, where she earned both her bachelor's and master's degree. So please join me in welcoming Cheryl.
Thank you, everybody. Good afternoon. It's wonderful to be here. Wonderful to be asked back. I did do a brief training on this for a previous deflection echo series not terribly long ago. This one's going to be a little bit longer, and kind of the way that I approach this one, or the slide deck that I'm using, is integrating both partner-inflicted brain injury as well as overdose-related brain injury. And as Ashley said, which, by the way, hi, Ruth Samara, it is good to see you. I'm really happy you were able to join. It's been a long time since I've seen you, so it's good to see you. As Ashley said, my 18 years of clinical work and counseling work was in the treatment of substance use disorders. And when I came to ODBN 3 years ago, 2022 is when I started. I started working pretty closely with Rachel Ramirez, who is the founder of the Center on Partner-Inflicted Brain Injury at the Ohio Domestic Violence Network. Started learning a lot about partner-inflicted brain injury, which was something that in the domestic violence field, not a lot of people were talking about or thinking about. And literally like a lightning bolt moment for me, I thought, whoa, wait a minute. I worked with countless people in my 18 years, so hundreds of people in my clinical work that had overdosed. And not ever in that 18 years when we would see certain things happening in groups with our clients and not being successful in treatment and not being able to successfully complete treatment and maintain their recovery, not once did I ever have a conversation with a colleague about, well, if they've overdosed 5 times, 10 times, even one time, and many who had been, in violent relationships multiple times, had trauma all throughout their life. Not one time did I have a discussion with someone like, maybe we're seeing these behaviors because they might have cognitive impairment. There might be a brain injury present. So I'm going to share my screen, get started with the actual presentation. And I did choose to add some information about partner-inflicted brain injury in here as well, because you're very likely going to be working with people who have experienced both. If you're responding to overdose or substance dependence, the likelihood that the people you're working with have experienced some kind of abuse in their life, particularly partner abuse, is pretty high. So depending on the statistics you look at, 40 to 60% of people with substance dependence disorders have experienced trauma in their childhood, adolescence, adulthood, or all of the above. So I really wanted to start with brain injury caused by domestic violence. And these are not to be thought of as separate and distinct things. These are to be thought of really as combined things, again, because of the overlap, but also because I don't want to give the impression that there's a distinct difference in brain injuries from people who've been hit or hurt in the head or had anoxic hypoxic brain injury from strangulation versus anoxic hypoxic brain injury or TBI from substance use or overdose. Those brain injuries may look very much the same, but I wanted to at least distinguish them in some ways. There are definitely some nuanced differences between the two, and particularly with the recovery period for brain injury between the two. So just to set the stage of what we're talking about here, for traumatic brain injury, we're talking about a bump, blow, or jolt to the head. And this should not be discounted necessarily when overdose occurs. Obviously, when a person overdoses, chances are they're falling down, depending on what position they were in when they were using. So they may have a traumatic brain injury, but more often what you're going to see with overdose is anoxic or hypoxic brain injury. Anoxic brain injury being a complete loss of oxygen to the brain, so they have stopped breathing, and hypoxic brain injury being a decreased oxygen to the brain, which is going to happen really if you're using a central nervous system depressant drug like heroin. You're already affecting your breathing and the amount of oxygen that's getting to your brain just by virtue of using the drug. Whether it's enough to cause a brain injury or not, that it kind of depends. But if you're overdosing and you're still experiencing some shallow breathing, it could be shallow enough or not enough breaths are happening to supply the brain with oxygen in the way it needs. Our brains are extremely oxygen dependent, particularly certain areas of the brain that are really oxygen dependent. And if any decrease of oxygen to the brain certainly can cause cognitive deficits or cognitive problems. So when we're looking at like a strict definition for partner-inflicted brain injury, what we're talking about is when a person's brain is hurt through intentional strangulation and or blows to the head. If you know anything about domestic violence or how abusers tend to target areas of the body with physical abuse, the head is a pretty common place to target because any bruises are covered by hair. So the chance, they may throw somebody into a wall. They may, just, throw somebody to the ground, not just, but throw somebody to the ground where their head may be hurt. But there are there's a lot of research that supports that injuries to the head are pretty common because they can be hidden more easily than injuries to the arm, injuries to the legs, injuries to the face, like black eyes. Those are pretty obvious things that people are going to ask about. Abusers don't want people asking about those things, so they're going to likely target areas of the body that are more hidden. So we're talking about, of course, TBIs, concussions, or other types of brain injury like anoxic hypoxic brain injury, which you would see more with strangulation or some kind of restricted breathing. An abuser may be sitting or applying pressure to the chest, which is restricting breathing, so it's not technically strangulation, but they're restricting the breathing of somebody, maybe even holding someone in a bear hug long enough to restrict the amount of oxygen that's going to the brain. So, but strangulation, which, by the way, in Ohio is, I think, the last state, and fairly recently, where strangulation became a felony. Prior to that, it was a misdemeanor. So I'm pretty sure we were the last one to do that. Excuse me. So when we're looking at head injuries as a result of partner abuse, what we're asking for or looking for is, have they ever hit or hurt the person in the head, hit you in the head with something, pushed you into furniture or walls, made you fall down? If they have violently shaken you, we think about that with shaken baby syndrome and things like that, but even shaking an adult person, your brain has very little space between where your brain is and where your skull is. Excuse me. And the frontal lobe, or the frontal part of your brain, right behind your skull, are little bony protrusions that stick out that if your brain, the frontal lobe of your brain rubs against them enough, either from shaking or your brain is being kind of jostled around in your skull, can wear off neurons and neuronal connections on the frontal lobe of the brain. Now, jetting over to looking at substance use just for a second before we officially get to it, the frontal lobe of the brain is responsible for problem solving, decision making, social connections, so many of the things that we need in recovery. So if there's damage to the frontal lobe of the brain, there may be a deficit in that person's ability to think through. I know in all of my years of substance use counseling and treatment, we would always say, you play the tape through, think through to the end, think through to the consequences. If you're thinking about using, you want to think through to the end of that and think through to the consequences. Well, if there's damage to this part of the brain, their ability to do that may be compromised, and they may not be able to think through. Impulsivity increases when there's damage to the brain, and of course, in recovery, one of the things we want to do the most is decrease a person's impulsive reactions. Their impulse in relation to their desire to use, or their thought process, their activating events, all the cognitive behavioral therapy stuff, to really be able to stop themselves from taking that next step towards returning to use. When we have damage to the frontal lobe, midbrain, that can affect a person's ability to do that. I also want to look at, are they putting their hands around your neck? It does not take a ton of pressure to decrease oxygen blood flow to the brain. It does take a while for a person to go unconscious when you're strangling them, but it doesn't take much to decrease the flow of blood and oxygen. So even minimal amount of pressure can cause that to happen. If they've slammed your head into something or done something, anything else besides like literally putting their hands around your neck that made it hard to breathe, as I mentioned earlier, like sitting on their chest or restricting their breathing in some other way. So I gave you in the definition of traumatic brain injury that it is a bump, blow, or jolt to the head. What that does is it stretches, pulls, and damages the tissue of the brain and affects the neuronal connections of the brain when you do that. Inflammation in the brain can cause widespread damage. So if there is a jostling of the brain, or the brain is kind of like smashing against the skull in some significant way, that can cause the brain to swell. And of course, there's not a lot of room, as I mentioned, for the brain to grow in the skull. Once it hits a certain point, it's going to cause severe problems for that person. They could, be comatose and need brain surgery to relieve the pressure on the brain. So it can get to places where it is very, very, very serious, severe, and potentially life-threatening. And of course, neurons cannot regrow. They slowly form new connections. So if you're causing neuronal damage or connections where the neurons, are communicating with each other, they have to reroute themselves if there is damage. So that may affect a person's ability to do many different things. We'll talk about lots of the symptoms, cognitive symptoms, emotional symptoms, physical symptoms of brain injury a little bit later. But when you've seen one brain injury, you've seen one brain injury. So I don't want to give the impression either that brain injuries look alike across the board, because they do not. Literally, you could have a person who has the exact same experience, maybe two people who've been strangled, but their brain injury symptoms may look very, very different. So literally, you've seen one brain injury, you've seen one brain injury. Typically, when we think of concussions, we think of football, we think of sports, and I guess I just want to ask a question of all of you. You can unmute or put it in the chat, however you choose, whatever is comfortable for you. If you're a sports fan of any kind, or you watch sports, even if it's just on in the background, when a football player gets a concussion, they go down on the field, you can hear the helmets cracking together, and you see somebody laying on the field, like in the picture to the far right. What happens for them? What's the response on the field? when a football player goes down? What happens?
Cheryl, are you asking like what's the response around them or what happens to them individually?
Yes, I'm sorry. Thank you for clarifying that. Yes, around them. What
Hmm.
happens around them?
This is Davita. To me, it seems like around they're scared. Um, the other players are concerned.
Mhm.
And
Yes, yes, that's very true. Thank you, David. I appreciate that. And yeah, I see in the chat, trainers remove them from the field after checking the player out. Yeah, what you see, um, there's another comment in the chat. Let me see if I can pull it up. Medical is brought out to evaluate them. They're taken off the field. Yeah, there is an immediate response. There are 5 or 6 people who come running out or more who come running out in the field. They're asking them, what game are you playing? Who are you playing against? What's the score? What day of the week it is? They're immediately checking for signs of concussion. They're removing them from the field of play. They're bringing them into the medical tents. They're checking them out. There is an immediate medical response. Now, I'll ask the same question of a person in a violent relationship. When a person who's being abused gets hit or hurt in the head, falls down, what's the environmental reaction? What's happening for them? It's a pretty one word answer.
Nothing.
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 Yeah.
Nothing's happening for them.
At best, it's treated like a crime scene, trying to get facts, but at worst, not a whole lot.
Yeah, exactly. And you're also talking about a situation where this person does not have a helmet. This person does not have padding. This person has absolutely no training in how to, football players are constantly practicing how to take hits, how to give hits, how to, avoid hits to the head. Survivors of violence do not have that same ability. They do not have that same training. I am so sorry. My computer is just, there we go. It's freezing up for some reason. It's taking its good old time today. But when a person who's experiencing violence has the same thing happen, and I did say in the chat that someone said it's almost worse. It's almost, sometimes they're getting hit harder. They're getting hit more frequently. They're getting hit in ways that are, who knows how much damage can be done by the ways in which they're getting hit, the frequency, the amount of blows that they're getting. We think of sports and there's immediate protocols put in place and all kinds of things that happen. But with survivors of violence, we do not have that. We do not have that. And their ability to recover, what's needed with a brain injury is rest. Stay out of, bright lights, don't look at screens too much, rest your brain, take care of yourself. How much ability do you think survivors of violence have to just lay down for a week and not do anything and take care of themselves and eat well and get plenty of sleep and all of the things that are really needed for the brain to heal? That's not happening. They get up, do what you got to do, and the abuser is right back at them, telling them, hey, you better get dinner on the table, you better take care of the kids, you better do X, Y, and Z. So you really do not have the ability to care for yourself typically. That people in sports who get concussions are encouraged to do and have the ability to do with a lot of medical attention. Strangulation, I imagine most people know what strangulation is. Choking is another word that people use, although choking refers more to something that you're like food that's blocking your airway, but it's used sort of as the common vernacular instead of strangulation. But the more accurate term is strangulation, which of course is pressure applied to the neck. It restricts oxygen and nutrients to the brain, which of course causes hypoxic and anoxic brain injury. Causes damage very fast with very little pressure applied. And altered consciousness, plus the lack of visible injuries, plus no access to medical care, plus the lack of screening anywhere equals minimization of brain injuries go undetected and identified. There's a woman that often presents with Rachel. She's a survivor of Rachel Ramirez, who I mentioned earlier. She's a survivor of violence, and for years, she experienced many symptoms that turned out to be the result of brain injury, but because of misdiagnosis, she had, if I'm remembering correctly, about 26 different diagnoses over the course of the years that she was struggling with her brain injury. And nobody was even asking about brain injury, despite what she was telling them. And she struggled to the point where she was considering suicide because of how she couldn't remember things. She couldn't, she would lose sense of where she was. She would have physical pain, all kinds of things that were happening for her, and nobody was looking at it as brain injury. And Stevie, I see that you have a hand raised. Do you have a question?
Yeah, I just was curious to know, like I'm listening, I'm paying close attention to everything and even the pictures. I see there's a lot of it's just women getting beat up, but it's a two-way street, especially nowadays. A comment that you made was like the aggressor expects like the food to be on the table, take care of their children, and if you listen to that, it's like saying it's pointing at the male.
Mm-hmm.
So I was just wondering why it's like not, you know what I mean?
You know what? Thank you, Stevie. I appreciate you saying that. I hear what you're saying. You're right. I am presenting it very much as female survivor, victim, male abuser, and you are absolutely correct. Men are victims of domestic violence. Men are victims of strangulation. Men are victims of women or other men hitting them in the head, neck, and face. Statistically speaking, does it happen more in the heteronormative male abuser, female victim? Yes, statistically, those are the higher numbers. But you're right. In these presentations, and I very much appreciate you pointing that out, because I never want to give the impression or minimize the effect that violence has on men in this country in intimate relationships, be they heterosexual relationships, gay, trans, doesn't matter. Domestic violence knows no bounds with regard to that. It happens in every single culture, to every single race, to every single gender. So you're right about that. And I will try to be more mindful throughout the presentation to not be so put gender boxing, if you will. So thank you. I appreciate you saying that. I really, really do. So with anoxic hypoxic brain injury, as I mentioned, the brain is incredibly oxygen dependent. When the brain is deprived of oxygen and nutrients to the brain, that's what we have. Violence and overdoses are the two main causes of anoxic hypoxic brain injury. And, we'll get, you're welcome, Stevie. Thank you. When we get to overdoses, again, there are some nuanced things with overdoses, a few differences when you're looking at what happens with an overdose versus what happens with partner-inflicted brain injury. But again, I don't want to make it seem as though the brain injuries are necessarily different in that way, that the effect can be the same. And a significant impact on executive functioning, including delaying gratification, putting on the brakes, and regulating emotions, which, again, as we know, in recovery from substance use, it depends on being able to delay gratification, put the brakes on, and regulate emotions, as well as being able to engage in social interactions. I know in my time of working with substance people who had substance dependence disorders, I ran groups forever. We as part of the groups, the expectation was you go to support group meetings. So all of those are social interactions. In group, you're with 11 other people. You're going to AA, NA, or other types of support group meetings where you are encouraged to get a sponsor or somebody who can be a peer support for you during your recovery. And because of how brain injury can impact that, the ability to make those connections can be compromised. And I know, again, the substance treatment field, and listen, I worked in it for 18 years, and I am very proud of the work that I did. I'm very proud of the agencies that I worked for. I really am, but it is an extremely punitive system. It is a very punitive system. If you do not maintain recovery, there are consequences to that. The majority of my clients were court ordered to me, majority of them, throughout all my outpatient work as well as my residential program. The majority were court ordered. They were part of drug court, they were part of regular court system, probation, children's services. If they did not do things the way we asked them to do things, they were punished for it. I cannot tell you how many letters I wrote to probation officers saying, person's not paying attention in group, person is not attending their appointments, person is not, doing X, Y, and Z. And many of those people probably wound up going back to jail or losing their children. And I can tell you, when I really started thinking about how many of those clients may have had brain injury, and it wasn't because they didn't want to do what we were asking them to do, but perhaps they couldn't do what we were asking them to do. I can tell you with every ounce of me, that is a heavy burden to bear. It is a heavy burden for me to bear because I didn't know what I didn't know. But there could have been many interventions to help people who otherwise went back to jail or had some other kind of significant life-altering consequences because I did not have the information that I have now. And it is a heavy weight. It really is. So in looking at, we're switching over to the more overdose-related brain injury section of this. And this I thought was an interesting graphic. And just wanted to pay attention to a couple points on here. This came from a Drug Abuse Warning Network through SAMHSA, so you can access this if you want to do a little more digging into this particular graphic or any of the other research or resources that they have. But 180 per 100,000 people were treated for non-fatal overdoses in the emergency department, which equated to exactly 599,075 visits in 1 year. So these are non-fatal overdoses. That is an extremely high number of people. Now, I'm not suggesting that every one of those almost 600,000 people had a brain injury, but I know from other committees I sit on, other groups that I'm part of, the Forensic Nursing Network and other medical personnel, and I've asked them, what happens in the emergency department with overdoses from the medical perspective? What is it? And it's basically a treat 'em and street 'em kind of mentality. It's, to their knowledge, nothing is being asked in terms of brain injury, CAT scans, MRI, like nothing. It's get them in, make them comfortable, bring them out of their overdose, make sure they're well enough to walk out the door, and out they go. Now, chances are what is going to happen without any significant intervention is the person may return to use almost immediately. If they've been Narcaned, of course, that's going to throw them into withdrawal. And if they're fearing that or concerned about that, or they're just not ready to stop using, what you have is a lot of people leaving an emergency room with minimal care to their brain, and they're possibly going right back out and using again. What that does is, and here's where one of the kind of differences is, a person who's experiencing violence as a result of an abusive relationship may be able to tell that something has changed, that something's different in their behavior and their emotions and their physical self. If they are not using drugs or there's not otherwise an impairment to them, they may be able to tell, like, hey man, ever since the last episode of abuse, I've had terrible headaches, I can't remember things. But that ability to recognize something that has changed in your thinking or emotions or physical self, if you're using drugs, soon after an overdose, you may not be able to tell that something has changed. You may have absolutely no idea that you're having headaches, that you're not able to remember things, that you're forgetting where you're going. Like that could be construed as an effect of the drug or just not noticed at all. And this isn't even getting into what drugs themselves do to the brain. So using a drug on top of an injured brain can certainly increase the damage over time or impede the ability to recover from that damage down the road if you're able to, tell at some point, like, hey, something's not right here. You get into recovery, you stop using, and you're like, whoa, something's not right. That period of time may be a pretty significant period of time between the time that they've overdosed or potentially had a brain injury and the time they recognize that they have symptoms. And these things can be compounding on top of each other, one after another, for extended periods of time. So again, what we're talking about with hypoxic brain injury is, cognitive impairment to memory, attention, mental processing speed, executive functioning, emotional dysregulation in the form of lability, impulsivity, irritability, and apathy. So when you see some of these things or when I would see some of these things in clients, we would almost always default to, well, they must just not be engaged, interested in recovery, ready for recovery. It was always sort of this default position that there was something that they were kind of intentionally doing or not doing, that they were not wanting what we were offering, basically. And, again, hindsight being what it is, that was a huge misstep to not be aware of this information and be able to say, well, wait a minute, maybe that's not the case. Maybe they are very interested in recovery and they can't figure out why they can't control their thinking, their impulsivity, their emotions, why they're angry all the time, like all of these things. Maybe it's a cognitive issue and not a, hey, I'm gonna, I just don't care kind of thing. And the impact on functions it's similar to TBI. So it's not with hypoxic or anoxic brain injury. You may see some similar things to what a traumatic brain injury would result in. But for substance use or dependence, from having a traumatic brain injury, even if you did not have substance use disorder, substance dependence issues, substance use issues prior to a brain injury, if they have a brain injury resulting from, in this case, domestic violence, frequently, and in one study, it was a multi-center study done where 70% of people receiving acute rehab after TBI were prescribed opiates during their hospital stay. And I believe I have a slide that has it. I can't remember if it's this presentation or not, but for an impaired brain, your ability to regulate your substance use and how the substances affect you changes. You have a more powerful or potent effect of your drug and decreased ability to regulate your substance use when you have a TBI. So even if you didn't have a substance use problem prior to having a brain injury and they prescribe you opiates as a result of having a TBI because of the pain or headaches or whatever they're prescribing it for, you may have a difficult time regulating how much of those opiates you're using, and they may affect that brain, that injured brain, in a more significant way than they would if that brain had not been injured. And due to a decreased ability resulting from traumatic brain injury to control impulses and self-regulate, increased risk of opioid use disorder. So there needs to be communication with the medical field about, like, hey, if you're prescribing opiates for brain injuries, there's a greater risk that this person can develop an opioid use disorder, and we need to be monitoring that, and we need to be paying attention to that, even if there was no prior history of opioid use or certainly disordered use. It has been demonstrated that survivors of TBI are at risk for problem substance use, in particular alcohol misuse. So that was one of the highest substance misuse, substances misused was alcohol post-injury, and that's mostly symptom management. It's what's happening to them, the pain that they're experiencing, or the difficulty with emotional control is often then controlled by street drugs or alcohol if there's nobody paying attention to this and saying, hey, let's help you figure this out. But with misusing alcohol, opioids, any other type of drug to symptom manage, of course you have much greater risk of developing a dependency disorder. And increased alcohol use following a traumatic brain injury may further impair judgment, increase in impulsivity, perhaps increasing susceptibility to developing disorder, as I mentioned. So lots of risks, even if you didn't have a pre-existing disorder, to develop one after TBI. And these next two slides, some of you may be very familiar with this, but I use this presentation to talk to people who weren't as, possibly didn't understand as much what is expected of people when they are on probation or when they are involved in substance use treatment. And so these are just some of the probation parole expectations that I could remember off the top of my head that my clients had to engage in. So they had to make sure they attended their probation appointments. They had to get and maintain employment quickly. Their POs were on them. Like, if you need to get a job, you need to get a job. They, of course, had to maintain their sobriety. They had random drug testing, paying fines, community service requirements, driving restrictions if they had licenses at all, seeking permission to change place of residence if they needed to move closer to some kind of resource or something. They need permission to do that, or may have to change probation officers. And attend and comply with treatment. So most of the time, if they were going to be placed on probation, part of that expectation was you go to treatment and you do exactly what they tell you to do, or else. And so if you're looking just at these, with a person with a potential brain injury, attending appointments can be difficult. Remembering when they are or getting to them can be hard to do. All of my years, 6 years, I worked in residential, and clients would, and this is embarrassing, like, for me, but I'm going to put myself out there. My clients would come to me and say, Cheryl, can you help me read the bus schedule? Nope, I sure cannot help you read the bus schedule because I have absolutely no idea how to read the bus schedule. So you're going to need to ask one of the advocates because I could not possibly make sense of that. And I do not have a brain injury. Now, if you have a person that does, and they have to figure out what bus to get on, even going from, I worked most in Portage County my entire career in Northeast Ohio, getting from Kent to Ravenna, at some point the routes changed, and it would take a considerable amount of time to get to Kent, Ravenna. Sometimes they'd have to change buses. All of that can be exponentially more difficult if you have an injured brain. Getting and maintaining employment, the intensive outpatient groups I ran, 9 to noon or 6 to 9 p.m. So they would work all day, fatigue their brain, and then have to sit in group for 3 hours that night after working all day. And with regard to men, I know that the men that I worked with mostly throughout my career, they were able mostly to find pretty physically taxing types of employment, landscaping, roofing, construction, things like that, where they were able to get in without a lot of scrutiny in terms of their past legal histories. So they were out in the beating sun all day. They were doing hard physical labor. And that's not to say that women weren't. It's just that was mostly what I saw with my male clients. They're out in the sun all day. They're fatiguing their brain. They're fatiguing their bodies. And then they have to sit and learn for 3 hours and sit and engage in discussion about sobriety for 3 hours, 3 nights a week. And get to random drug testing if their POs called them to do that, and all of that, and be able to navigate that without losing sense of like their dedication to recovery, or being able to do that without getting in trouble for not showing up, or any number of reasons. was very difficult. And I can think back on many people that just stopped coming. They just stopped coming to treatment. They just stopped coming to groups. They just didn't come anymore. And of course, we assumed it was because they just didn't want to do it. They just weren't ready. And again, how many of those people may have just been like, I can't do this. I don't know why I can't do this, but I can't do this. And how sad and unfortunate that is, that this piece of the puzzle was missing, at least at that time for me. And this, of course, was just what was expected for substance use treatment. Attending appointments, abstinence only expectation, at least in the treatment world I worked in, abstinence was the expectation. You were free from all mind-altering chemicals. Of course, as I mentioned, you have intensive outpatient groups that were 3 days a week. We had them on Monday, Wednesday, and Thursday for 3 hours each time. That was for 1 to 2 months. Then they had aftercare for 1 day a week, 2 hours for 12 weeks with 11 other people in the room. Then they had to attend individual appointments, support group meetings 3 days a week, and random drug screening for treatment as well. This is an enormous amount of expectation on somebody who, in many cases, just possibly weeks prior, if that, were actively out in the world using drugs. And then they got caught, they went to court, and the judge said, nope, you're done. And now you have all of these expectations. That's hard, period. Whether you have a brain injury or not, it's extremely stressful. It's extreme amount of expectation. And add cognitive impairment or brain injury on top of that, and it's an unrealistic expectation, an unrealistic amount of expectation, at least as quickly as we expect these things to happen, is certainly unrealistic. So just looking at some of the cognitive symptoms of brain injury, and I am being mindful of the time we're trying to be. I see a question in the chat. I hear you and I agree, but how do we determine if mental laziness common among the SUD population and a TBI of some type? Certainly there is a better way than have you ever had a head injury. There are certainly, I think that's a good starting point, is are we just asking the questions, which in treatment circles, again, that I was in for as long as I was in, we weren't even asking the question. We weren't asking these questions of people who told us that they had experienced significant trauma in their life. I worked with clients. Most of my clients did not have one incident of trauma. They had multiple incidences of trauma, starting in childhood, going all the way through adolescence and adulthood. And we weren't even asking questions about being hit or hurt in the head or being strangled or what potentially could have been the outcome of those incidences of abuse in terms of their ability to cognitively be attentive to what they needed to do. And we definitely weren't asking that as a result of overdose. So I think at least the knowledge, this person is overdosed. We are asking a series of questions to determine whether or not there could be a potential brain injury here. And I think in terms of counseling anyway, I can speak from that perspective. We are pretty uniquely positioned to at least help with symptom management. You certainly can refer to doctors. You can, they can go through all of that. There should be some kind of medical recommendation if they're experiencing some symptoms, like the ones you're seeing in front of you. If you're seeing these things in people, I think probably the salient point is maybe not to assume mental laziness or a lack of caring or a lack of concern about their recovery. Let's not have that be the default position anymore. Let's ask a few questions and listen to them. Like, something is not right. Something is different. Something is not clicking in my head anymore. So much of that can be pushed off as just, well, of course it's not. You've been using drugs for 10 years. That happens in the medical field. That happens in the helping professions. Outside of the medical field is we kind of sort of default to, well, yeah, of course you have headaches. You used methamphetamine for 10 years. And that may very well be why they're having headaches. That may very well be the reason that they're experiencing some of these things. And it could very well be that they don't want to engage in recovery and there is no brain injury. Certainly not suggesting that you see these things and immediately that person has a brain injury. But what I am saying is I think we need to do our due diligence to at least start asking the questions and being mindful that this is a thing. This is a thing that probably a lot of people are experiencing and they don't have words for it. So we need to help them put some words to perhaps what they're experiencing. So not everything just sort of falls to, well, they just don't care. And so we're just going to write the letter and send them to jail. And again, I'm not saying it's as flip as that or as intentional as that, but that's kind of how, from the client's perspective, it might feel. Like I do care about my recovery. I do want to do this. I don't know why I'm experiencing what I'm experiencing or doing what I'm doing. And I think we need to listen to that and maybe start asking some questions about it. So with the cognitive symptoms, what the people may be struggling with on the left-hand side, I'm not going to go through every single one of these. I'm happy to send this PowerPoint along if that's helpful for people. But we're looking at, of course, issues with memory, comprehension, getting started on tasks or following through, maintaining attention, problem solving, which may look like, with the people that you're working with, not starting or following through with plans. They appear to be not interested or engaged. They don't care. They're unmotivated or lazy, mentally fatigued easily, missing deadlines, all of these things. So I can tell you unequivocally, a lot of my clients had these symptoms or showed these behaviors. And again, I'm not saying that in every single circumstance it was because they had a brain injury, but I never once asked a question, because I didn't know to ask the question of why that might be happening, other than you just don't want this. And that's kind of where I'm landing on this, kind of the hill that I'm dying on, so to speak, is if we have more questions, if we add more questions to assessments and really look into this, then maybe we start seeing that, hey, there's ways we can help people get through this differently than we currently are. And I did see your question in the chat. Let me go back to it. Okay. Now, how do we determine between TBI and stuck trauma? Again, that's about asking questions, which I do have a slide about some of the questions that we can ask coming up. Things that could be added to assessment, things that could be added to just any conversation that you're having with people. If we're looking at emotional symptoms, of course, on the left, you see becoming easily frustrated, anger, rage, mood fluctuations, exacerbated mental health challenges, and experiencing anxiety, depression, post-traumatic stress disorder. Anxiety and depression maybe weren't present prior to a brain injury, but certainly because a brain injury can cause mental health issues to begin as well post-injury. So you may be seeing anxiety and depression after a person has overdosed or experienced anoxic, hypoxic, or TBI brain injury, and they've never experienced these things before. So just know that with mental health, that can begin after a brain injury as well, and not necessarily be there before that. And you also, look at on the right side of it, being non-compliant, saying or doing things without thinking, difficulty getting along with other people, following directions, talking about hopelessness. You also have an increased risk of suicide because of some of the symptoms that people are experiencing from brain injury and some of the mental health issues that can follow with a brain injury. So we do want to be mindful of listening to those things with people we're working with. They're talking in ways that lead you to believe they may be thinking about suicide. Just know that may increase if brain injury is present. With the physical symptoms, you may have sensitivity to light, poor sleep quality, headaches, migraines, dizziness, fatigue, difficulty swallowing, and neck pain, which would be more resulting from a strangulation incident if it's a partner-inflicted brain injury. But all of these other things with anoxic, hypoxic brain injury certainly could be present. And so you have a person who's dealing with a lot of pain. They're bothered by noise or lighting. tripping or bumping into furniture, which could look like substance use. If a person's not walking right, they're kind of, got a little change to their gait, and you think, well, they're, that looks like they might be drunk. It looks like they might be high. Again, like not kind of defaulting to that necessarily, and really looking for how can we be asking some more questions. So, of course, the treatment implications, you have goal achievement, perhaps an impact on goal achievement, treatment success or completion, impact on confidence to do the things that are being asked of them, impact on the therapeutic alliance, and of course, increased risk of suicide, as I mentioned. Did see something popping up in the chat. If I can get my cursor to, you sure can refer for a brain scan. They would probably have to see their primary care physician if they have one first, and get a referral for a CT or MRI. The problem is, in some cases, is as soon as somebody says, "Hey, I'm a substance user. I have got a substance use disorder or something," if they disclose that, sometimes that can be dismissed in the medical world as well. Like I said earlier, of course, you're experiencing these things. You've been using drugs forever. So it might be helpful if you have a peer supporter or an advocate or someone who can attend that appointment, or at least help them prepare for it, to write down, hey, these are things that are different. I've never experienced these things before, and help them compile a list of symptoms they're experiencing and what happened. Have overdosed however many times, been hit or hurt in the head from a partner issue, or I fell and hurt my head, or was in an accident as a result of my substance use. It certainly can help with providing the doctor with information on what's different about this, and maybe why to not just look at this as a result of substance use. Most of this stuff, and in the interest of time, I think I've already talked about a lot of these things. Something just popped up in the chat. But yeah, I certainly would encourage you to refer anybody that you think may have a brain injury to get some medical attention, because you never know how serious that could have been. And they may not be able to remember how long they were unconscious. They may not be able to remember if they hit or hurt their head after they overdosed and fell down. They may have absolutely no idea that they cracked their head on something. And that may not be something they saw in the emergency room. So it's certainly good to refer to medical care, but that doesn't, thank you, Ashley. That doesn't necessarily mean that medical care, if they're like, nope, I'm not going to a doctor, no way, okay, then let's shift over to talking about how we can manage some symptoms. Let's talk about what you're experiencing and how we can help you with that. So if they're resistant to medical care and you can't force people to do it, then at least how can we help you with some of the things you're experiencing, and treatment plan around that, or with peer support or anybody else that's intervening. Like let's create some goals and objectives and be thoughtful of the things that you're saying you're experiencing. So here's some of the questions to add to an assessment or intake, or your conversations with people. Of course, if they've ever been hit or hurt in the head as a result of violence or in a way that caused them to lose consciousness. If they have any sense of how long they were unconscious, or hey, maybe 5 minutes, 5 minutes. Once you start passing the 5-minute mark of decreased oxygen, you're almost certainly moving into brain injury territory. Did you seek medical care? How many times have you overdosed? Have you overdosed recently? Was anyone with you that provided aid or assistance? How long after your overdose did you use again? Did you feel different or off after this overdose compared to other times? Have you noticed a change in balance or coordination? Have you felt dizzy or had pain in your head, neck, or face? For the last two, numbers 8 and 9, there are definitely, and I can share some resources that you can also get on ODVN's website, the Ohio Domestic Violence Network's website, and download tons of brain injury resources that are part of the Center on Partner-Inflicted Brain Injury. There's a chats tool that has some of these questions on it. Lots of other resources that Rachel Ramirez has worked on over the years. But there are some that are like, look, if you're losing your ability to hold your urine, or you're defecating yourself, you're not able to, you have severe migraines or headaches. Some of these are real significant warning signs that you really should seek medical attention quickly. Some are not as serious in terms of medical attention, but again, I think no matter what, medical attention certainly isn't going to hurt anything. Finally, this is something that I had the pleasure of working on with Dr. John Corrigan at the Wexner Medical Center at The Ohio State University. We did a one-page, this is front and back, making groups effective for clients with cognitive impairments. I don't know on this call how many people run groups or are part of groups. This can work in any group situation, and there's certainly things on here that could work in non-group situations, but we focus specifically on treatment groups for this. So we're looking at compensatory strategies, group structure, and behavioral issues, just some things to consider in a group setting and to help prepare clients for being in a group when they have brain injury. So this would be a known quantity. We know someone has cognitive impairment, and we want to help them prepare for these things. But if you want to structure your groups this way just because, this certainly isn't going to hurt anybody that doesn't have a brain injury, and in fact may make group more pleasant or palatable for people, whether they have a brain injury or not. And I'm happy to send this along as well with the slides. And I know that we only have a couple minutes left, but I'm happy to answer any additional questions that people have. I will stop sharing my screen.
Well, thank you, first of all, for joining us. If you have to take off, registrants will get access to slides, the materials that Cheryl's talking about, and a situation summary with a link to the video. So if you do have any questions, Cheryl's email will also be on that. And Cheryl, if you want to stick around for questions, I'm happy to open the floor to that.